We are live.
Good evening, postgraduates, and my regards to all the mentors. Let me welcome all the panelists as well as the speaker for today, Dr. Suven, Dr. Virendra, Dr. Gaurav, and Dr. Amla. And I'm really thankful to you for consenting for this particular program for our postgraduates. So, without much ado, can I request our member ARC from North, Dr. Tinku Balu, to carry forward the proceedings? Dr. Tinku, over to you.
Hello, thank you, Dr. Prashant. So, very warm welcome to our postgraduates, faculty members, and everyone who's joined us live on YouTube and Facebook. So, today is the 116th episode of the AIOS ARC PG teaching program. And today's episode is something that every ophthalmologist should be conversant with, that is pupillary dilatation, drugs, and devices. So, as we know, a good pupillary dilatation is important not only for a good examination and diagnosis, but also for a good surgery. And to help us to understand the finer nuances of this, we have a very distinguished speaker, Dr. Suven Bhattacharjee. Dr. Suven is a consultant at the Nayan Eye Center in Kolkata. So, Dr. Suven, your name is synonymous with, pupillary dilatation. Dr. Suven is not only a very excellent surgeon, but also an excellent innovator. He has devised the three pupillary expansion devices, that is the BHEX, the BHEX2, the BHEX Octa, and also the 23 gauge forceps. And all these are, patented and being used worldwide. So, Dr. Suven, hats off to you for getting Indian ophthalmology, the worldwide recognition, and your devices have become so popular and eased, the surgeries of so many ophthalmologists. So we're really looking forward to your talk as you walk us through the practical aspects of pupillary dilatation. Thank you so much for consenting to be a part of our PG teaching program. We also have a very distinguished panel of experts who will be giving their inputs at the end of Dr. Suven's talk. So we have with us Dr. Amala George, who's the Deputy Director of the UVA Services at the Shankar Nethralaya, Chennai. Dr. George is not only a renowned clinician, but also an excellent researcher, and she is widely known for her expertise in handling complex inflammatory disorders. Thank you, ma'am, for consenting to be a part of this program, and a very warm welcome to you.
Thank you.
We have with us Dr. Gaurav Luthra, who's the medical director of the Drishti Eye Institute at Dehradun. Dr. Luthra is a leading expert in cataract and refractive surgery, and he also has a lot of innovations to his credit. We keep hearing him in conferences. He always has something new to talk about. So thank you, Dr. Gaurav, and looking forward to your inputs.
Thanks, Dr. Tinku. Thanks for inviting.
Thank you. And our third panelist is Dr. Virendra Agarwal, who's the director and chief consultant at Dr. Virendra Laser and Phaco Surgery Center at Jaipur. Dr. Virendra has a very vast experience and is renowned for his expertise in lasers and in cataract surgery. And we're really looking forward to your expert comments, sir. A very warm welcome to you.
Thank you.
Thank you, sir. Thank you all for joining us. And with that, I invite Dr. Suven Bhattacharjee for his talk on pupillary dilatation, drugs, and devices. Over to you, Dr. Suven.
Thank you very much, Dr. Tinku, for the very kind introduction. And I thank the All India Ophthalmological Society Academic Research Committee for this invitation. Let me share my slides. Yes. Are my slides visible?
Yes, yes, they are.
Okay. So, yeah. So, I again thank the AIOC and ARC and all the ARC members, especially the discussants and the moderator today for this opportunity. And well, when we talk of pupil dilation, drugs and devices, we are talking of two situations: non-dilating pupils and intraoperative miosis. And I'm Suven Bhattacharjee. I do have a financial interest in the devices mentioned, some of the devices mentioned over here, by virtue of my ownership in MedInvent devices. And I gratefully acknowledge the contributions, video contributions from Dr. Deepak Megho, Dr. Pradeep Mohanta, Dr. Nilesh Kumar, and Dr. Saurabh Patwardhan. Now, as I look at this particular talk or class, I would say the purpose is to empower our PG students with knowledge that can be applied. Let me just change this to, yeah, which can be applied to the student at the time of residency, as well as in their professional careers going forward. Why is a small pupil such a big problem? Primarily because of the inadequate visibility. Now, when the pupil size drops from 8 millimeters to 4 millimeters, actually the viewing area drops to 1/4, to a quarter, from 50 square millimeters to 12.5, and that's the hindrance that we have, and that leads to vision-threatening complications. And the other part is that unpredictability of IFIS with iris billowing, intraoperative miosis, and iris prolapse. Now, how small would we call actually a small pupil in cataract surgery? I think conventionally it's about 5 millimeters, which would be the cutoff. If the pupil fails to dilate beyond 5 millimeters despite our maximal mydriatic treatment, we would kind of consider it a small pupil. Now, in the OPD or in the OT, what would we consider a safe preoperative pupil size to eliminate the risk of IFIS? Now, this paper in 2011 by Casuccio and co-workers concluded that if pupils 7 millimeters or smaller, the risk of IFIS existed regardless of alpha blockers. So that literally throws out our definition of small pupil. Now, it is a good practice, I believe, in the OPD to record objectively the size of the pupil in millimeters. And you can easily do it on the slit lamp by the height of the beam measurement, which is there. And it's a very easy method. And because there are situations where one person does the examination and another person does the surgery, it's always a good idea to record all these which are relevant to a small pupil: the antechamber depth, pupil size, posterior synechiae, fibrotic pupillary membrane, pseudoexfoliation, and hardness of the cataract. To understand the medications, we need to understand the autonomic pathway with the sympathetic and the parasympathetic pathway, which control the meiosis and mydriasis. So by and large, the meiosis is controlled by the parasympathetic. Both the diagrams are the same, actually represented differently. Parasympathetic controls meiosis by the release of acetylcholine and constriction of the sphincter pupillae, and the sympathetic, which is the fight or flight. So there is release of norepinephrine at the alpha-1 receptors, and there is dilatation by stimulation of dilator muscles of the iris. Having said that, now we come to the drugs that act on it. So we either need to block the meiosis or the sphincter pupillae, or stimulate the dilators. So phenylephrine is an alpha-1 agonist, and it stimulates the iris dilator. It's the commonest first-line drug. In fact, now we use mostly combinations. And tropicamide, cyclopentolate, and atropine are basically parasympatholytics, or more specifically, antimuscarinic. So they paralyze the sphincter muscle. Then as we know, tropicamide is pretty fast-acting. If we're using cyclopentolate for whatever reason, we must be wary of the fact that they can cause extrapyramidal symptoms, though rarely. We have all seen it in our careers once or twice. And if you're using atropine, yes, in uveitic patients, we would be using it, but it has a long-lasting effect for almost 12 to 14 days. Now, NSAIDs act through the cyclooxygenase pathway. They inhibit that. So there, it's relevant by preventing the meiosis caused by prostaglandin release. There is a theory where, especially in at-risk patients, we may start using it 1 to 3 days pre-op. It has benefits even for the retina, so it clubs in both the benefits. Now, a word about preoperative NSAIDs. It's not a fail-safe thing, and it really does not actually serve a primary role in pupillary dilation. It does not augment pupillary dilation as such. What it does is prevents the induced meiosis by prostaglandin release, which would happen if you touch the iris. So NSAIDs are not required if you don't touch the pupil with the phaco tip or the second instrument, or you don't allow the nuclear fragments to rub against the iris and the pupil. Intraoperative mydriatics, which is actually where we are mostly working, is which we need to summon at when we are in a crisis. We could use epinephrine and a 1 in 1 million dilution. These are, like I said, an alpha-adrenergic agonist. It maintains dilatation, and all mydriatics kind of to some extent reduce IFIS, but nothing is fail-safe. the combination of phenylephrine and ketorolac, which is available as Omidria, not in India, but overseas, and it maintains mydriasis and reduces pain and inflammation because of the ketorolac component, and it maintains dilatation. Now, Phenocaine Plus is available in India, and in Europe, it's available as Midrain. That is a combination, I think, which is most often used over here operatively. It's a combination of tropicamide, phenylephrine, and lidocaine. It provides anesthesia and dilatation. Again, these will not actually give you a fantastic effect. If you are getting a fantastic effect on the table, you must realize that the dilatation preoperatively was not good enough. The drops were not instilled properly. But it does help maintain the dilatation, and of course, it does provide anesthesia, which may keep the patient more comfortable. Epi-sugarcane or sugarcane was something which was a compounded thing which was used in the past. Now we have more commercial preparations. So that was epinephrine and preservative-free lidocaine. We need to be wary of the possible side effects, local and systemic. Free radicals are generated and they may cause corneal damage. TAS is a known complication of anything that is introduced into the eye. Endophthalmitis is also a concern. So if you're really not going to gain significantly, I'd rather steer clear of it. Inconsistent pupil dilation and ventricular fibrillation is been put. Nevertheless, it does not affect the blood pressure. So you can use it in hypertensives relatively safely. Now, this is something which has, again, another compounded mixture, which was used, at least in my residency when I was in JIPMA, I have used this. I don't know, Dr. Amala George may be able to enlighten us if it's used still in uveitic patients. We used to give the subconjunctival. But for postgraduates, you must be aware of this because these can be questions in your examination. So Midricaine 1 and Midricaine 2, this is just basically the concentration doubled. So the lower dose is used for pediatric patients and the adult dose is the twice of it. It's a combination of procaine, atropine, and adrenaline. So that is used subconjunctivally in uveitis or in patients where you think you can break the synechia by giving a subconjunctival injection. Yes, IFIS is very common in India. In fact, the incidence is higher. And surprisingly, tamsulosin, alfuzosin, and use of hypertension were found to be important risk factors. This is a landmark paper by Dr. Shilpa Goyal and co-workers. Now, if you look at the etiology of IFIS or the factors, the drugs which can cause IFIS or the conditions, I think the list is actually getting endless. There are newer conditions being added. So alpha-1 antagonists, endothelin receptor antagonists, angiotensin antagonists, nitrates, antihypertensive drugs, hypertension itself, which means every alternate patient that we are operating on, diabetics, chronic heart failure. So practically no amount of history taking can really prevent surprises, and we should rather brace ourselves for the surprises in the operation theater. A few important facts about IFIS, like I said, history cannot really be foolproof. Pupil size, again, is not a great indicator. IFIS can occur 1 year after tamsulosin has been discontinued. It can occur within 3 to 7 days of initiating tamsulosin. And stopping tamsulosin has actually zero value, and it should not be done because you may land up with uterine retention. And we must remember that women very often these days are prescribed tamsulosin for UTI. This was another landmark paper by Chang and Campbell, published in the JCRS in 2005, which changed our understanding of small pupil when we realized that unlike the non-elastic myotic pupil, the IFIS pupil actually immediately snaps back to its original size following attempts to stretch it. So that brings us to the conclusion or the derivation that small pupils are actually of two types, either elastic or non-elastic, or the rigid variety. So an elastic pupil is very much like a rubber band. You can stretch it and probably any pupil expander would work. Whereas a rigid or a fibrous or non-elastic pupil is much like a string. You need to break it or tear it. So you need either two Kuglin hooks or a bulky expander to do that. Now we could check the rigidity of the pupil or the elasticity before we start. Inject a little bit of BSS through the side port or ring lactate, whatever you choose, and the pupil momentarily will expand. As soon as you've done the paracentesis, you can do that. Whereas if it's a rigid pupil, you will see that no amount of injecting BSS into the anterior chamber actually even helps budge the pupil. And that's when actually you need to use two Kuglin hooks to stretch it, because this is not an elastic pupil. So you will have to facilitate the use of by creating some amount of elasticity over there by breaking those fibrotic bands. So this is a two Y hooks used. I'll come to the instruments a little later. So these two Y hooks being used for pupil stretch, and this is quite effective. So mechanical pupil dilatation, we come to now, we moved out of drugs and we now come to mechanical pupil dilation. Like I said, pupil stretching is not effective in IFIS and it may be counterproductive actually. But of course, controlled stretching before using an expander for a rigid or fibrotic pupil is very useful. And in the list of, in our armamentarium, we have the iris hooks or the retractors and the pupil expanders of the rings, the BHEX, the BX 2.0, B-Octa, and the Malugin ring. There are others which I'll be talking about, which we should be aware of whether we use them or not daily, but we must be aware of them. Now, where do we inject viscoelastic when we choose to use a pupil device? If you inject viscoelastic anterior to the iris, which we usually do to deepen the antechamber, actually it is counterproductive. The iris is plastered to the anterior lens capsule, and we find it difficult to place our devices. So the best place to inject viscoelastic is a little in the antechamber and a little under the pupil margin or the iris to lift off that pupil margin so that you actually cause bowing of the iris a little bit and keep the antechamber slightly underfilled so that you can use the devices under the pupil margin effectively. Now, these are important instruments which you may be handed down in during your instruments table, and we have to understand the Kuglen hook can be used variously, and it's called by different names: push-pull hook, ball dialer. It can be called a collar-stud hook or a H hook, depends upon whether it's the ball or it's actually a flatter one version of it, but they pretty much serve the same purpose. Now, it has also been called a Hirschman hook at times. Many times in literature and in instrument books, you will find this being referred to as the Hirschman hook. But my understanding is that the Hirschman hook is something like this, which is a little bit of rounded, and it's more like a fishing hook or a different kind of hook. Now, this is a Bond micro hook, which is again used for iris manipulation or stretching. And this is the Y hook which I showed you in the video earlier. So these could be instruments which you may be able to, or may be asked to identify, and you should know about them. And this discussion will spin off into small pupil thereafter. And this is something we must know. Although it's of historical interest, I don't think many people are using it, but if it is there on your instruments table, you will be asked about it. And this is basically a lot of iris hooks or iris retractors put together in one sleeve. And actually one is there behind, which remains stationary. And the rest of the three, there's a two hook version also. The other three kind of stretch the pupil. And that is when you get a pupil stretched. And that is basically a single stretch which serves the whole purpose of using, but maybe a bit cumbersome to use. Now, it's important to visit the history of iris retractors or iris hooks, because we sometimes anterior segment surgeons want to take credit for that, and it's been kind of wrongly known, but actually the inventors or the people who brought flexible iris retractors to us were Eugene Dejoie and Dyson Higginbotham. This is in 1991, they published in June 1991, they published this in the American Journal of Ophthalmology. And this gave the whole structure. Whatever we're using now is a derivation from there. The celastic sleeves, the flexible iris retractors, and the hooks, everything was described in 1991. This Richard McCool in 1992 described the iris hook, which was published in the JCRS. And so this is predated by the AGO publication by Dejuan and Higginbotham. So they should be rightfully given credit for that. And Louis Nechamin published again in 1993, which is actually a closer version to what we use today. So if you talk about the high-risk hooks that we use now, they are mostly made of polypropylene or nylon, mostly polypropylene that we use. They're angled J-shaped. There's a hook tip, there's a shaft, there's a sleeve or a stopper, and they could be used in 4s or 5s, depends upon what you prefer, a square or a pentagon. And usually it's available in 5, but it's a surgeon's choice how you want it. These are very flexible and very easy to use, and all of us have graduated from iris hooks to the rings. This is a very old video, but I think it serves the purpose very well. It shows us all the steps so you don't overfill. You make paracentesis clear corneal, posterior directed. 0.5 is good enough, and leave a conjunctival mark, but otherwise make it a little embarrassing. Later, you can't find those paracentesis. Retract the stopper in advance so that you're not embarrassed. and hold the hook sideways and enter, and do not pull the hook all the way. Just advance the stopper adequately, which will provide enough dilatation. I prefer to make the phaco incision only in the end after the hooks are in place. And we need to be careful about the size of the capsular, so don't get carried away. And we need to remember that the iris is now at the limbal plane, and the pupil margin is often anti-flex. So when you're introducing your instruments to the side port, we need to be wary of that so that we do not damage that iris over there. So remove it. It's very easy to hold the stopper and advance that hook, turn it a little and just yank it out, and it straightens momentarily and comes out. Really doesn't cause any corneal damage. Of course, you could also turn it and wriggle it out. That is one of the ways of doing it. That's your choice. Rhomboid or pupil was proposed by Oetting and Omfrey, where you keep a hook sub-incisional. But if you're planning a sub-incisional iris retractor, it's better to plan well in advance so that you can plan your phaco incision accordingly. Now, this is a place where I'll show you a disaster that I had, not a cosmetic disaster, I would say, because this pupil was small and I retracted it fully all the way to one side, and I was asking for a tear, huge iris tear over there. Now, a tip over here, if you are afraid of engaging the capsular excess margin, you can use the second instrument from the side port and just tent up the iris over there, and you can be absolutely sure that you've not engaged the capsular excess margin. And then you can advance that stopper. Now, the downside of iris hooks is the 4 incisions that we have, and there's generally a tendency to over-retract and cause iris sphincter tear, and there is a whole lot of space that is wasted in the corners, which we needn't actually do. Then, like I said, the entire iris is raised to the limbal plane, so you're working at a more anterior plane, so you are likely to cause more endothelial damage and iris trauma. The time taken is a little more with iris hooks. This is a study in JCRS, and this is a documented study. Of course, it depends upon your comfort level. If you have been used to using iris hooks for a long time, it may not take so long. And if you have, there have been too many pressure fluctuations, and they have the iris hooks can leave a mark on the iris, which may not be cosmetically acceptable, and a disfigured pupil at times. We must give credit where it is due. These are the giants who have actually shaped the present pupil expander rings, though they may not have really stood the test of time. But the Greater ring, the Lee, the Milverton ring, and the Morcher ring, these are the predecessors of our current day pupil expanders that we use. Credit must be given to Boris Malugin for bringing the big breakthrough by bringing us the Malugin ring. It has really been the most popular device over the past, I think, 2007 to now. It's almost 28 years, 18 years. The downside again here is they've got biplanar scrolls, and that's the pain point. It requires a little bit of loading by withdrawing. A little bit of skill is required to engage those scrolls. It's difficult to get those 3 in one go, but with practice you can do that. It requires an offshore manipulator. And what is a problem is the unpredictable crushing which can happen, or while twisting that can happen. I'll just show you that in this video. If you're a little careful and you watch, as we are trying to remove that ring. Now that takes a little bit of learning to do. Now, if you see that iris over there at 6 o'clock has got, yes, crushed over there and held, and the Malugin ring has joints. It served a very useful purpose, but then there is a risk of the joint breaking. So why does that crushing and release happen? Because the Malugin ring has those helical scrolls at the corners, which are actually torsion springs. And the gap in them makes them also a compression spring, and that can catch the iris unpredictably. And you don't know which scroll is going to catch and which is going to release. The snagging happens because this is a biplanar device, and as it enters the eye or exits the eye, it can catch the corneal lip, and it can snag the incision. It's the 2-plane design which is actually the problem. There is a Gupta ring which is available in India, and now this is a close cousin of the Malugin ring, a slightly different arrangement of scrolls and the flanges, but pretty much the same principles. Again, the same difficulties with the scroll, same pain points. The scrolls might disengage. Engaging them requires a little bit of skill and patience, but there are a significant number of users who are happy with it. And the last scroll is really always difficult because it's a little stiff. It's nylon, and it kind of takes a little bit of effort to tuck that last scroll over there, but then it gives a good mydriasis. Removal is not so difficult because those scrolls kind of straighten as you pull the device out. You really don't need an injector or a device to pull it out, so it can just be taken out. Another downside is that it does leave marks on the sphincter and tears over there because it's a relatively rigid device. Now we come to the BHEX. The BHEX, original BHEX with the flagship product that was there was actually a hexagon. It's the hexagon with 6 flanges and 6 notches at the corner. The flanges are relatively stronger and the notches are thinner and flexible, and there are tabs for holding and manipulation. And it's recommended to use the BHEX 23 gauge forceps with this. We extended the BX to the same design to BX 2.0 and the BX 8.8 BOCTA 8.00, which is the extra large expandable pupil expander. The same principles, the same design almost, except that there are 8 notches and flanges over here, and the flanges are actually folded. Now, what advantage that gives is these flexible folded flanges can straighten on demand when they are pushed against, and that gives us a larger ring on demand, which is actually very helpful in SICS when you want to prolapse the nucleus into the anterior chamber. If you look at the inventive step of the BHEX or the BOCTA compared to all the other rings, the Malugin ring, the I ring, or the Gupta ring, see, the Malugin ring and all these rings have pockets or scrolls which are kind of perpendicular to the iris plane. So the pupil comes and margin comes and engages with the ring over here. But in the BHEX or BOCTA, the entire device is in a single plane, and the iris now actually goes up and down. So that was the inventive step, and that obviates the need for an injector. The pupil margin straddles the notch, and as we know, the iris can bend easily without any harm. So let's watch a BHEX in action, and this is where we put BHEX, a little bit of viscous elastic into the anterior chamber, a little under the pupil margin, and then we hold the device flange and advance it into the anterior chamber. We tuck the distal flange first, and then alternate flanges go under the pupil margin, and we have a hexagonal pupil. It can go in through actually even a 1.2 millimeter incision, and it can always exit through even a 0.9 millimeter incision. So it's so thin that it's practically not noticed in the anterior chamber, and it allows free movement of your phaco probe and second instrument or the IO probe, probes into the IA probes in the anterior chamber. It's really ultra thin, and it actually doesn't come in the way of the IOL injection. You can go under the IOL and do whatever you want. And removal is actually very, very easy. That's easiest among all devices. Just grab a flange, advance it, disengage the notches on either side, and drag it out. And it leaves a wonderful round pupil, which is a pleasure to watch the next day after surgery. If you come to the BOCTA, this is the design advantage. This was the change that we brought into it. It's a much larger device, and it becomes larger on demand. And the folded flanges actually straighten, and that gives us that extra advantage, which is so helpful in SICS. That's again, so apart from the fact that the device can actually take an elliptical shape according to the nucleus, it can also enlarge. So that allows pretty much any size nucleus to be delivered into the anterior chamber. If you really want the specifics, this is there, and the details are here. Actually, I'll make the whole PowerPoint presentation available to you, I think in the chat or on the YouTube comment section, so you can download freely. It will be available on WeTransfer for download for the next 3 days, and then it will be available from our drive. You can download it at any time, and you're free to use it any which way you wish, unrestricted use. This is the removal of the BHEX through the 0.9 on 1 millimeter side port incision. And that is a huge plus when you're stuck in an IFIS situation with the iris prolapsing through all ports. No device actually can do that. This is a general usage recommendation. For phaco, we could use BHEX, BX 2.0, or BOCTA, depending on the merit of the situation. For SICS, only the BOCTA is recommended. And first-time users or early users are better off with the BHEX because it's very soft and gentle. It's easier to use and start off with. For rigid pupils, we always recommend a bimanual stretch with 2 Kugler hooks. That gives you the best utilization of the device. Now, this is a BOCTA being used for SICS, and as you can see, once the 4 flanges are gone under, you have a huge pupil, and that can allow real great visibility for SICS. And this is a B octa being used through the side port, actually being inserted. So you have a well-formed anterior chamber while you're tucking the flanges, and you can see that very, very bulky nucleus being delivered very easily into the anterior chamber. It's a real big one. Now, this is B octa being used in intraoperative meiosis in a very hard cataract. And where you in hard cataracts, you can probably chop and make the fragments as small as you want, and then but then a little bit of extra pupil dilatation or enlargement really is very comforting, and you are kind of operating as if you never had an intraoperative meiosis. That is very helpful for your psych and to keep you composed during a crisis situation. Now, this is for the other devices that we must know and will be available as spotters, or they can be asked about in the exams. So the APX pupil expander is actually basically 2 iris hooks put into one. And so instead of 4 incisions, you require 2 incisions. It's a relatively bulky device. The spring is very tough and it's difficult to handle. I have no personal experience, but from what I've seen and heard, this is the expand iris speculum, again from Diamatrix, and this is made of nitinol. As you can see, those actually scrolls or those bends are getting stuck in the incision, that's snagging the incision. So carrying it in with a forceps is actually really difficult, and it is a challenge to manipulate it. And that is actually the reason all the devices, be it the Mulligan ring, the Gupta ring, or the eye ring, or the expand, all of them have injector, because it's basically the injectors don't serve a sterility or a useful purpose in injection. It actually circumvents the problem of snagging of the incision, and that is why the injector is provided with the device. If you look at this now, once you have an injector, it kind of negates or obviates that the snagging. So, but yet it's a little jerky, but much better than what it was with forceps. So we must understand that actually the injectors were not meant for our convenience. It's the convenience of taking the device into the eye and bringing it out. It's not actually the sterility or other things which the injectors help with. So again, you need to withdraw it into the injector to have it safely delivered. This is the eye ring from Beaver Visitec. So here again, there are pockets on the side. It's again, the vertical profile is a little larger. So it's a bulky device. And if you understand that these pockets are resting in the mid-periphery, and the mid-peripheral anterior chamber is actually much shallower than the central anterior chamber. It would be probably half the depth of the central anterior chamber. So it could be a bit touch and go with the endothelium being touched. These are polyurethane devices, and they have something called live hinges. You have them in all those containers these days, those plastic live hinges. A Canabrava ring again is one more which is available. This is made of PMMA. It's pretty stiff. There is an upper part and the lower part, two plane. Again, it's a biplanar device. I again don't have any personal experience, but those who have used have conveyed that it is a little difficult to manipulate. This is a elastic pupil, so probably it's going in much easier, but a little bit of rigidity, it might be a challenge to put this device in place. Now, how you wish to tear the rigid or elastic pupil depends entirely on your choice. And so if you wish to do it with 2 coulombs, you're okay with that, then you could use a BX 2.0 or B octa. These are 75 to 125 micron thin devices, as thin as a human hair. But if you would like to do it with the pupil expander, you have a little poorer control. You could use any of the other bulky devices, but they occupy more space in the anterior chamber and they obstruct movement of the instruments. To summarize the drugs that we may use, pharmacological topical, we have phenylephrine, tropicamide, atropine, and NSAIDs. These are the first line that we use. Anti-inflammatory as can be used as adjuvants, as ketorolac, prednisolone sometimes. They prevent meiosis. And intracameral, we generally use epinephrine and then Omidria or Phenocaine Plus or Midrin. I've used the trade names over here, but then I've told you the composition earlier. And they maintain dilatation fairly well. Viscoelastic support, well, not really great. They may contain IFS for a period of time, but really not really foolproof. The actual fail-safe device in fail-safe option in small pupil is a mechanical device. Whether you choose iris hooks, BX, BX 2.0, B-Octa, or Malyugin ring, when drug dilation fails, or whenever you have a reason to believe that the intracameral mediatrics are not helping or will not help, it's best to opt for a mechanical dilatation. It's absolutely fail-safe. And here is a huge chart about pupil expansion devices that we have, rings. It's a little busy slide, but I've tried to put everything on one table. So for exam going, you can always actually refer to this. So the BX pupil expander is made of polyimide. It's hexagonal, planar ring with 6 flanges and 6 notches. It's ultra thin, jointless, easy to use, can go in through very small incision. The 2.0 is a thicker and slightly larger version of the same. The B-Octa has got 8 points of fixation, and it can provide extra large expansion and can expand on demand. And it's the only available device for MSICS. So, and the Malyugin ring has actually stood the test of time. It's polypropylene square ring with helical scrolls at the corner, 8 points of fixation. It's popular, but then there are joints and which are glued together and that can break. And there is a bit of unpredictability with the iris crushing and device twisting. Eye-ring has also been used. Expand anti-iris speculum, I don't think is very popular. Anyway, you have it all on over here. And if you would like to know more and learn more about small pupil, we have a group on WhatsApp which discusses practically anything and everything to do with small pupil. I'll be happy to let you into the group if you could scan that QR code and put in your request. I'll be happy to answer any questions now or in future. Thank you very much again for your kind attention.
Thank you, Dr. Bhattacharya, for that very complete and comprehensive presentation with lots of practical pointers for our postgraduates. We have some questions in our chat box. One question asks that what is the learning curve, with using these pupillary expanders, the BHEX pupillary expander to be more specific?
Yes, specifically with BX, there is hardly a learning curve. Actually, till recently, we had never had a hands-on workshop, and most users use it by just watching videos. It comes very intuitively, and it really doesn't. Any anterior segment surgeon is conversant with the use of a microsurgical forceps, and the device is actually, there's no rocket science, but then that again can be a little bit of, it can be, you may think it to be too easy. So it's better to watch a few videos before you go in for the surgery, and then it becomes easy. It's actually, there is hardly any learning curve.
And is it necessary to use the forceps, the 23 gauge forceps?
Absolutely, absolutely. This is specially designed for the BX because ergonomically designed, and because it's got to see all the vitreoretinal forceps are much longer. The stock is much longer. You yourself being a VR surgeon, and actually I am a trained VR surgeon, and I used to be a VR surgeon once upon a time. I've hung up my boots for the last 15 years. So I have damaged a few of my quite a number of my VR forceps because they are pretty long. And when you're using them in the anterior chamber with the bridge of the nose and stuff like that, you end up damaging them. So that's why this was designed, and the short stock, and that makes a lot of difference, and that short curve, and the fact that the jaws open perpendicular to the squeeze handle. So that is not available in all the other forceps. So it is essential. You can do it with a Sinskey hook, but then it can be touch and go, and you can actually rip the anterior capsule. So it's safer with the forceps.
Thank you. Thank you so much. We now move on to our panelists. I first invite Dr. Amala George. So, Dr. George, you have an experience of handling the most complex uveitic cataracts. So, if you could give us some tips on, handling these eyes before, like how to dilate the pupil in post-uveitic cataracts, intraoperatively or preoperatively.
Thank you.
What is your protocol?
Yeah, Dr. Suven, that was such a comprehensive talk. I enjoyed your talk and the revision of the entire pupillary dilatation.
I enjoyed preparing, actually. I went back to basics after a very long time.
Very, very enjoyable, very comprehensive. Thank you so much. You had said something about midricaine, whether it's used.
Yes. I wanted to know what's the practice now?
Yeah, we don't really use midricaine now. except when we want to teach the postgraduate somebody to, about it. But I know I used it a lot.
Yes, same here. In JIPMA
Yeah,
as a resident, I know we used to do that compounding in the ward.
So that, and at that point it was necessary. I think little later on we realized that in an acute situation, the important thing was to get the steroids in fast and use atropine, and that was probably finally what made a difference. But so we don't really use it nowadays. But yes, historically that was very useful.
It can be a good Viva question always.
Yeah.
Yes.
Yeah. Then the other thing. See, for uveitis per se nowadays, I mean, with a lot of management, we don't really have really bad pupils quite as much as we had before. I think the worst are the ones where you also have a very shallow chamber where there's a lot of peripheral anterior synechiae also in addition to everything else. So in those situations, sometimes it's difficult to get your side port, flatten release some of the synechiae, get some space to put in a hook or a expander of your choice. So most of those cases, really speaking, the most versatile instrument is either one of the Coughlin hooks or the iris retractors, mostly because we do need some space to put something inside. But for the newer the pupil expander devices, especially the BHEX, I think is what most people find easy to use. And so they definitely help a lot of the more conventional small pupils. The only other thing I needed to say was the iris retractors. Sometimes you know how it is when you also expecting zonular dialysis. We use the iris retractors so that once they're in place, in case we see that zonules are dodgy in one place, we can always slip it over the capsule also, so that to stabilize everything until we finish the phaco part, and then we'll have to decide about the placing of the IOL. That convenience is there. And then the other thing was when we make the entry for the iris retractors. I mean, I used to use the keratome to make those side openings, but now I use the 26 gauge needle more often because it's really small and it's much easier to both insert as well as take the iris retractors out, and it's a little more self-sealing than the other knife. And I spent because I think in the old days I would spend a great deal of time trying to seal all the 7 openings that I've got in the cornea, and so now I use the 26 gauge needle for the iris retractors. If there's anything else, I can't offhand think of anything more. If there are any other questions, I'd be happy
We'll
to.
come back. We'll come back with more questions now. Dr. Luthras, you've been handling a lot of complex cataract surgeries. Anything that you would like to add to this or give any tips to our postgraduates for handling small pupils?
Sure. So I think that's a real masterclass, Suven. You really took us through it and really enjoyed it as well. And very hard work behind it, because you had to, kind of cater to the residents and yet have everything that it takes for everybody to understand it. So I think, the devices have been really useful, and I do use all these devices as well. And of course, the Pinocaine, which has again become really useful. And I do tend to use Pinocaine first in these situation. Sometimes it gives you that additional, just that 1 millimeter, which
minimum 20,000 kilos. If 100 tons goes.
Okay, so sometimes that just saves the day, because you just need that little bit of thing, and then you don't want to go in with the devices. But of course, very often Pinocaine just doesn't work at all, and you have to still go for something. Now that said, and I do love to use both iris hooks, the Mulligan's ring, and the BHEX. I've used all of them, and I enjoy each one of them. The BHEX, of course, is very comfortable to use. In fact, sometimes for my femto cataracts, I've used them because it goes into a much smaller incision than what the Mulligan ring goes through. But then I don't routinely use it. It was probably just that I wanted to prove to myself that you can do a small pupil with femto, if you have to. But traditionally, you would not really want to waste time on doing all that. I do have that thing to put in here, that of last few years, I actually don't end up using devices most often. Once I think you gain that little bit of a proficiency in cataract surgery, you don't really need a very large pupil. unless you have something which is really bound down and a very rigid small pupil which is just not allowing you to. So sometimes, you just want to, have a safe people. For example, if you have a very hard cataract or a complex, subluxation or a posterior polar cataract, then you don't really want to go in from a pupil which is smaller than that 4 millimeters size. But very often you can actually handle most of your routine cataracts through a pupil which is about 4 to 5 millimeters, and with viscomydriasis and pinokin and stuff, you can actually get away once you're more proficient. But for residents, I think the message would be that whenever you are faced with a pupil situation which you are not comfortable with, you must use something to kind of give yourself more room so that your complications are less, especially the rexes should definitely go through properly, and then the cracking and everything. One area which the only one other area, I'm sorry, I'm taking it too long, but I think another thing which is really important is fluidics. And and as Suven also said, that with minimal contact with the iris, with your instrumentation, with your nuclear fragments, makes a lot of difference. I also feel that low IOP. I use just about 40 centimeter bottle height for my surgeries now, or an IOP of say about 25 to 30. That itself, and then also using very nicely sealing incisions. So my side ports are usually calibrated to all my instruments, and I don't allow much fluid to flow out. So usually at the end of my surgery, I've used just about 30 to 40 ml of fluid after a routine cataract case. So that turbulence of the fluid flowing around, and iris, the floppiness of the iris, all that sets in when you have a lot of movements inside the chamber with fluids and with phaco energy and a lot of vacuum and going close to the pupil. So I think if we refine our surgical skills, you will not really get IFS very often, and even small pupils can be managed very easily. So I think all those things put together should help.
Excellent pointer. Thank you so much. Dr. Agarwal, over to you for anything that you would like to add, any tips you would like to give to the PGs. Sir?
I think it was a pupillary device, but it was an expanded device for everything, that how to do a safe phaco. The only thing we all know, as Suven has also said, when the pupil goes down, the complication rates tremendously increases. So your pupil need to be big enough to prevent all kind of complications, particularly holding the capsule, causing the posterior capsular tear, leaving some residual lens matter into it, going some lens piece into the places where you can't see, and later on next day you see that the lens is there, lens matter is there. So these kind of things are very, very important. And the simple thing is that whenever you feel that you are not confident enough to deal with the pupil size you are having, don't let your ego come in between and use some or other device, whatever is convenient to you, what is available to you. Sometime it may be that you are not planned that the pupil may not dilate. But at the end, you are seeing it is not dilating. Gaurav is very correct that first choice goes into phenocan or something to put inside as a pharmacological dilation trial. I still feel that the patients, until having some synechia, I don't prefer to stress the pupil, except in some patients where there is a synechia or some kind of margin having a fibrous membrane. Then you stress that the pupil will really expand. But rest of the time, either you use some device, or if you can manage it. I think very correctly said, for PGs, the pupil should be minimum 5 millimeter. If it is not so, they should use some device or take help of the seniors. But for the people like us, many times we go with the smaller pupil also safely. And it depends on the type of cataract also. If cataract is choppable, then small pupil does not make much of the difference. You can do vertical chop. But if cataract is on a softer side and if pupil is not big enough, then it comes as a problem, because you keep on eating the central part of the cataract, and at the end you remain with the bowl. And you are not able to see the edges from where to hold the nucleus or epinucleus remaining there, and then it creates a trouble, and you try to push the iris by one or other thing and enter into the with the phaco. Sometimes you will catch hold of the iris, it may bleed also sometime, or you have a irregular size of the pupil later on. So I think the first choice should be, the pupil is not good enough, let your ego come in again, I'm saying, and dilate it, or use the device to make it dilate for your sufficient comfort. Because at the end, we have to deliver the result. It does not make sense that you have not used the device and you have completed, but you have created a complication which is not expected. And the complication rate has to be very, very low, because nowadays every patient understands and feel that cataract surgery is very safe. And we have to increase that faith in the patient's mind. that whenever somebody comes for catastrophe, they should be very happy that they, at the end, they will have the results what they wanted, and we want to deliver the best. So it is a very important topic, I think, for PGs to understand that what are the things available. And Suven has very correctly said again and again, some or other instruments may be shown in you in exams, and then if you can't identify, it will be a big problem. So try to solve the instruments, all the rings, and use them judiciously.
Thank you. Thank you so much, sir. Dr. Amala, in uveitic cataracts, is it important to look for that fibrous, membrane at the pupillary margin and remove it before we try to go in with any pupillary expansion devices? Or can we just go straight ahead?
Yeah. Because if you have a capsule membrane, I mean, you can't find any space to insert any device. So that's when the Coughlin hooks sometimes comes in place, because it'll help break the membrane. And sometimes you have a double membrane. You'll do what you think is a rexis, and then below that you'll find one more capsule.
Yes.
So you just should be on the lookout for some of these things when we do the uveitic cataract. And again, fortunately, this is less and less now because better management all over. So that's there.
Dr. Suven, we have another question, that which is the safest pharmacological device, drug to use when you have a posterior capsular rent? So with a rent and a small pupil, what would be the safest drug to use?
You see, these all the commercially available medications are already tried and tested, and they are not toxic, or least toxic. And in the concentrations that they are there, they are not really toxic to the retina. That I think you should be able to tell us also. So in the constant, because you're constantly washing away what is being put also. So, and it serves its purpose and it's washed out actually because of the fluidics. So yeah.
Yeah, why I asked this question is because recently there was a case of PCT and I injected phenocaine, and the patient was PL negative right after surgery. So I went and looked up literature, and they said that it could be the xylocaine and the phenocaine, or the phenylephrine maybe that caused a constriction. Though the patient's vision returned back.
CRAO? The patient had a CRAO?
No, nothing. It was just the optic nerve,
Optic neuritis. Okay, toxic.
No. Yeah, just maybe it was a very transient thing. The patient regained vision later.
Okay.
So it's like after we give the block and the optic nerve, loses its function. So
It
something
gets
like
numb.
that.
Okay.
Yeah, it just became numb. And so that's what I wanted to highlight this, that, I mean, we should be cautious while using phenocaine in patients with rent. I also looked up literature, and there have been some cases reported like
Wonderful.
this.
That's
Yeah.
learning. We'll be
Yeah.
wary of it.
So if
And one
anyone
gets
has
scared if it happens.
Yes, it was scary, but thankfully the patient recovered vision.
Also, Dr. Tinku, if I can just on the same topic, if we should probably try not to use drugs unless they're absolutely necessary, because indiscriminate use of drugs like phenocaine, etc. And I do remember one of our colleagues who called up. I did the initial studies on phenocaine about 5 years back before it was launched, and he called up to say that he started using phenocaine for all his surgeries, and he suddenly saw a higher incidence of CME. So he wanted to check whether I had noticed it. So I didn't use it in this. I mean, I wasn't using it in every patient, so I probably didn't get to see it. But after that, I've been careful, and I don't think there's any report on this, so I can't kind of say that it was phenocaine. But since that time, I do think that as we all probably are careful using any kind of unnecessary drugs in the eye when they are not really required.
Right, very well highlighted.
To agree with Dr. Gaurav, I don't use phenocaine actually. I use intracameral adrenaline if I want to use a dilating agent. Then again, for pain, intracameral lignocaine when you need it, So I'm hesitant to use my drugs with multiple this thing, and especially with phenylephrine, we've had a lot of systemic toxicity when we've used it. So we avoid using phenylephrine from the allergy point of view, from the raising the systemic hypertension. So as a result, but it is widely used. There's also some TAS, I think reports of TAS with phenylephrine intracameral, I'm saying, but so as a result, I tend to use intracameral adrenaline whenever I need something.
Thank you. So I think we have a few more
And for
minutes
the
left.
uveitic patients, I advise for the uveitic patients, instead of using hooks, you can sometimes use just the cannulas, like the visco cannula with the visco filled in. So you can create a plane and you can dissect it with the simple visco pressure also. So it will minimize the damage happening to the iris and later on the inflammation. So that can also be used. Or sometimes I just use the hydrocannulas to just sweep over the lens between the iris and the lens, and it will release the synechial which may not be there at the pupillary margin, which may be just behind or in the mid pupillary region. So this kind of thing is a kind of visco as a visco device we can use as an instrument rather than using actual mechanical instrumentation also.
Yes, that's true. And with the cohesive or the high molecular weight viscoelastic device like, Helon GV or something, that's fairly useful to see which are the synechiae that, actually need to be released and which are going to anyway get released by visco manipulation.
Dr. Gaurav, just a few tips for the PGs. What are the common mistakes that you see postgraduates making, that can cause a pupillary constriction during surgery or even in small pupils, mishandling? What are the 5, 6 important things that you'd like to highlight?
I think one common thing is that you have to be comfortable with the anesthesia. So of course, you should have, as a PG, you always need to have a good proper peribulbar blocks, and have ensure that the patient is comfortable, because otherwise it just prolongs the surgery. So prolonging the surgery in any way is going to cause more pupils coming down and having trouble. So other than that, you typically see more manipulation of the iris, phaco tips touching the iris or your chopper touching the iris, or so minimize the manipulations in the chamber. And sometimes you also end up seeing sometimes because they are not confident with doing iris plane phacoemulsification, so you might see that they might want to bring fragments up over the iris plane, and then they're all chattering around and moving. So I've seen a couple of our residents where they might just have few fragments floating around in the chamber and causing trauma to the iris and to the cornea as well. So these are other things. And then again, if your wound construction is not good and you keep getting iris prolapse from either the main port or from the side port, so I am a big proponent of having the right instrumentation and the right plates for the perfectly sized incisions, so that you don't have neither too tight nor too leaky incisions. Even the side ports I typically make to the exact size, as I said. So I make a 1 mm or a 22 gauge side port, and my cannulas, my irrigation aspiration and other things are all. Also, I feel that when I make the side ports, if you use something like one of those side port knives, which are I don't know what you call them. I think the 15 degrees or whatever. So it typically keeps getting wider as you kind of keep pushing it in, right? So those are the ones which most often people use when they're in training or whenever. So essentially, you don't have any control on the size of the side port. The more further you push it in, the more size of the side port you get. So I see that the risk of iris prolapse from those side ports is definitely much more. And when you start getting iris prolapse from the side ports, you start getting pupils constricting. One last thing I feel is that sometimes you have this it's a situation where the pupil comes down when you have all the fluid trapped behind the pupil. So it's like I'm forgetting the name of that situation when you have the pupil come down with the iris bombay kind of a thing happening, where the iris plane is pushed back. So typically when that happens, you keep struggling thinking that your pupil has come down. All you have to probably do is that move the pupil to the side with a wide tip cannula or a wide tip manipulator, or even with your chopper. And as soon as you release that trapped fluid from behind the iris, it tends to kind of fall back, and you can actually proceed. These are some things that come to mind, but I'm sure Tinku and you guys who train a lot of fellows in PECO would probably be more aware of what mistakes they make than I would be. So I'm sure you will have more things
I
to
think
add to
you've
that.
given some excellent tips. Thank you so much. And before we wind up, Dr. Suvain, just a quick, if you could highlight your journey into designing these devices. How did you actually, start, and what was the entire journey like? Just to inspire our PGs to be more innovative.
I'll be happy to talk about that. So actually, I was working at about the same time that the Malignant ring came. I was independently working on something. I mean, as usual in my early career, I had a lot of nasty cases, a lot of iris hooks to be used, and I wanted something easier. It's just that the malignant ring came earlier. And then when the malignant ring came, actually, even then I was struggling, 2007. So till 2013, I was actually struggling to get a design which would work. So anything I drew, I would try strike it out or throw that paper. And eventually it occurred to me that actually the entire problem was because these devices were in two planes. So if I could bring that down, effectively making it 6 iris hooks, that would actually, I started with a square. But then the square, in fact, I started with an open house kind of design. And the funny part was they had kind of hooks in the end to keep them engaged. So I didn't know about so much about elastic people. Actually, I have been instrumental in propagating the elastic people and rigid people concept because I burnt my fingers in my journey. So one fine day, I did this. One of my prototypes, there was a nylon, I think 50 nylon I was using, and it was an open house. I worked in one case, and in the other case, the legs came together and interlocked. And I had a tough time releasing it on the table. And I couldn't figure out why that happened. And then I realized, okay, then I went back and did a little more of literature search. Then I realized that there are elastic pupils and rigid pupils. So then closing this ring became essential. And when I was working on nylon, and nylon cannot be joined together end to end. So it requires something called ultrasonic welding, which is the technology I couldn't afford at that point in time. So it was funny, and I actually took a chance one day and I used Fevikwik. It worked. It worked. Of course, when I went on to make the device, and I had to use it under the microscope, use a droplet, and get the two things aligned so that they are not up and down, and they'll break otherwise. That was so. The whole idea was it became clear that if you can get it to a single plane, I wanted it to pass through a 20 gauge incision. Actually, that was my kind of goal. So towards that, the objectives kept kind of getting revised and kept getting modified as I went on. And then I realized that if I have a single plane device with notches and flanges, which can kind of open up and they can go through a very small incision, because I wanted it to go through a very small incision, the open ring concept was there. But then that failed. So I went to the closed ring, and the square was not working great. The hexagon, the square, what happens? The square again is like iris hooks. You have a lot of wasted space in the corners, and the corners are actually very close to the angle. So they can damage. So a hexagon was giving us maximum advantage.
Yeah.
So that's how it kind of went. That's another story altogether.
Okay.
Just a word for the postgraduates. If you want, I have tried to put that the presentation link from my drive in the YouTube comments section. So if you can copy it and paste it and click on put it in URL, you can download it from my drive, and you are free to use it any which way. Unrestricted use. You can use my videos, my presentations. I never have any hangups about people using it. So, and if you can't download it, please write to me, send me a WhatsApp. I'll be happy to share the link with you.
Thank you. Very generous of you.
Dr. Tinku, I just remembered something that we might want to add. I'm sorry, I'm interrupting you
No,
because I thought maybe if you're going to close, there's something which I wanted to quickly mention before we actually close up. There's something which I've been using very effectively is a irrigating wire. So, about 5-6 years back, I kept thinking that I need something during my, sometimes the pupil tends to come down after your nucleus is gone and you just have the cortex left and you can't get under it. So, at that point, I worked with Epsilon, and we devised this thing, which is basically an infusion handpiece, which has a wire in the front. It's very basic. It's no big deal, but it really helps because especially if you're doing torics or if you're doing, cortex extraction, when you want to have more visibility. So if you're doing bimanual cortex extraction, you can just use that Y kind of a thing, to push the pupil to the sides and go under wherever you want to go, visualize and get the cortex out without having to catch the bag or, without knowing where there is cortex. It's really, really useful. And you can obviously switch hands as well when you want to go to the other side. That's one area where it really helps. And especially because now more and more of us are doing more torics. So your toric marks tend to always, get under the iris. And this again becomes really useful because all you have to do is just push the pupil to one side and to the other side. So I find it very useful. And then 2-3 years back, I suddenly realized that my friend Kumar had devised exactly the same thing. And, just that his wire was not vertical, it was horizontal. So, and then I think, you kind of think alike. Most of us tend to reach the same place, but it's a very, very useful device as well. So.
Actually, it's a brilliant idea, Gaurav, because once we have the visco out, in a toric IOL, that's when we actually want to check again. And that we don't want to put in visco again into the anterior chamber. And having an irrigating Y would actually help us to see whether our toric marks are aligned. That's a good idea.
Great.
And it also helps you, realign it. For example, if it's rotated a bit, you can just go with that Y and to the haptic and just move it a little bit under infusion. And the infusion is on, so your chamber is always kind of full. So it helps in many ways, but I mean, it's just a small little tip that can
Thanks
add
for
to
that
it.
input. What's it called, Dr. Gaurav? What's
It's
the
an
device?
irrigating Y, which comes by my name from Epsilon. I have
Irrigating
no
Y.
financial interest,
So,
but yeah,
Okay.
if
irrigating
Gaurav
Y.
and Kumar thought of it together, then one limb of the Y would be Gaurav and the one other limb would be Kumar.
So when Kumar went on and won a prize on that video, and then when he won the prize in ACRS, I took out my 3-year-old video and showed him that, Kumar, this is what I was doing 3 years back. And then he said, "Oh, I didn't know about this." So that's okay. I mean,
that is the game of publishing. So if you
I
publish,
agree.
you have
Yeah,
it.
yeah.
That will be very useful, Gaurav, actually, because I'm using a Kuglin hooks to,
Yeah.
one hand the cannula and the
No,
other
it's
hand
actually very
a
useful, and
Kuglin hook
I'll
to try
share
and
a small
smooth it
video,
right.
and
So,
I find it very useful. Yeah.
and this is actually very useful.
Thank you for the excellent input. Yeah, I'm sure the peaches are going to look it up on YouTube or somewhere and find it. So thank you so much. Thank you, Dr. Suven Bhattacharjee, for that excellent talk. Thank you to all the panelists, Dr.
Thank you.
Amala George, Dr. Gaurav Rutra, Dr. Virendra Agarwal, sir. Lots of knowledge was shared this evening, and I'm sure this was a wonderfully informative episode for all our postgraduates, not only postgraduates, for every ophthalmologist that has been watching this episode. So a huge thank you to all of you. And with that, I bid you all a very good night. Also want to remind you that the ARC is back again every Thursday with a new episode. So every week we cover something new for the PGs. It's either a didactic lecture or a journal club, short case presentation, or interpretation of diagnostic modalities. So do tune in every Thursday from 8 to 9 p.m. for another episode. Thank you so much, and it was a pleasure.
Thank you.
Uh,
Bye-bye.
Thank you,
Thank
Dr.
you.
Bali.
Bye bye.
Thanks everyone. Yeah.
Yes, thank
Bye-bye.
you. Thank you.